Welcome to the Radonc Smart Review CNS Cancer Series.
Great to be here.
Today, we're really launching into a practical workshop designed for you, diving into spinal stereotactic body radiation therapy, SBRT.
Yeah, we're building on our previous talks about spinal mets, but shifting gears.
Exactly. Moving from conventional palliation more towards this high-precision world of SBRT.
Right. So the goal today is really to cover who to treat, the evidence behind it, how we actually delineate targets.
Those critical dose constraints, for sure, and how to safely approach re-irradiation, which is always tricky.
Definitely. Think of this as, your workshop session on getting comfortable with these advanced cases.
Okay, so to make this really concrete, let's use a framing case so we can keep circling back to it.
Good idea. Keeps it grounded.
So imagine you have a 68-year-old woman, history of metastatic renal cell carcinoma. And right away, that histology is key, isn't it?
Absolutely. Renal cell, melanoma, these are the classic radioresistant ones where SBRT really shines. Conventional doses often just don't cut it.
Right. So she presents with pain from a lytic lesion at L2, but importantly, it's described as stable. Her SINS score is 5.
Okay, SIN is 5. So spine instability neoplastic score, 5 puts her in that indeterminate or potentially unstable category, but often stable enough for SBRT. Requires careful thought, though.
Exactly. It's that score that helps us gauge the risk, right? Is the spine going to hold up to this high dose? A 5 is borderline, but generally okay.
Yeah, 0 to 6 is stable, 7 to 12 indeterminate, 13 to 18 unstable. So 5 is on the stable side of indeterminate. Crucial check mark.
And she has minimal epidural extension. We'll definitely unpack that. Plus, a great KPS, Karnofsky performance status of 90. Highly functional.
Perfect. I mean, this patient really highlights why SBRT is such a powerful tool in the right situation.
How so? Why is she such an ideal guide for our discussion?
Well, like you said, the radioresistant histology, it basically demands a higher ablative dose for any chance of real local control. Conventional RT just wouldn't pack the punch needed.
So SBRT offers that high dose.
Exactly. And her SMTIS score, being 5, suggests the spine can likely handle that ablative dose without collapsing. That stability is non-negotiable.
And the minimal epidural extension, that's the Bilski grade, right?
Right. That's probably Bilski grade 1C, meaning it just touches the cord, no compression. That gives us the safety window we need. If it were compressing the cord, SBRT up front would be, well, dangerous.
Got it. So her case really sets the stage for all the technical details we need to cover.
Precisely. Yeah. It makes the abstract concepts much more tangible.
Okay, let's broaden out then. You mentioned the radioresistant histology.
Yeah.
What are the other core indications for spine SBRT? Who are we typically thinking about?
Well, there are a few key groups. First, patients with oligometastatic disease, maybe just one or a few spinal spots.
So not just for palliation, but aiming for more durable control.
Exactly. The thinking shifts towards potentially eradicating those few sites, maybe improving progression-free survival, not just symptom relief.
Makes sense. And the radioresistant types we mentioned, renal cell, melanoma.
Sarcoma, some non-small cell lung cancers, too. Tumors where historically conventional doses were pretty ineffective. SBRT is a game changer for offering them actual local control.
And the third group?
Re-irradiation, patients who've had radiation to the spine before and now have a recurrence in that same area. SBRT is often the best, sometimes the only feasible option.
But that comes with its own major challenges, right? We'll definitely need to get into that later.
Oh, absolutely. Re-irradiation is high stakes.
You brought up the epidural extension, the Bilski grade.
Yeah.
You said it's maybe the most critical factor. Why is that? And can you walk us through those grades?
It really is paramount because it dictates the immediate risk to the spinal cord. The Bilski scale is our standard language for this.
Okay, so grade 0.
Grade 0 is simple. Bone-only disease. The tumor hasn't broken out into the epidural space at all. Cord's got plenty of room.
Grade 1.
Grade 1 is epidural extension, but it doesn't reach the cord, 1A, or it just touches the integral sac, 1B, or the really key one for SBRT, 1C. It abuts the cord itself, touches it, but doesn't compress it. You can still see CSF, cerebrospinal fluid all around.
So 1C is touching, but no squish.
Exactly. Think of it like a car parked next to the lane, not blocking traffic. That CSF space is still open. This is often the sweet spot for considering SBRT.
Okay. Then Bilski grade 2.
Grade 2 is definite cord compression. The tumor is squishing the cord, but crucially, you can still see some CSF signal around it.
So the traffic lane is narrowed, maybe down to one lane, but stuff is still getting through.
That's a great analogy. There's compression, but not a complete blockage. This is where upfront SBRT starts getting very risky.
In Bilski 3.
Grade 3 is the worst case scenario. The tumor compresses the cord and there's no CSF visible around it. It might be circumferentially encased.
Complete blockage. Road closed.
Exactly. Total chokehold on the cord. SBRT here is absolutely contraindicated initially.
Wow, okay. Those distinctions are crystal clear and obviously vital. So what's the hard rule then for SBRT based on Bilski?
The fundamental rule, the one you just cannot compromise on for safety, is that spine SBRT is generally considered safe only for patients with Bilski grade 1C or less.
Only 1C or less. Why is that line so firm?
Because the spinal cord has almost zero tolerance for additional pressure when it's already compromised. Even a tiny bit of post-SBRT inflammation or swelling, which is expected, could tip a compressed cord over the edge into permanent neurological damage, paralysis.
Right. You're not just risking pain, you're risking function. Irreversible function loss.
Precisely. It's a risk we just don't take.
So what if a patient walks in with Bilski grade 2 or 3 compression? What's the pathway then? SBRT is off the table.
Upfront SBRT. Yes, absolutely off the table. The risk is far too high. These patients need urgent surgical evaluation.
For decompression.
Exactly. Often they'll undergo what's called a separation surgery. The neurosurgeon or orthopedic spine surgeon goes in, physically removes the tumor that's compressing the cord, creating space.
They don't need to get all the tumor out.
Not necessarily for the purpose of enabling SBRT. The primary goal of the separation surgery is just to decompress the cord, to physically separate the tumor from the cord and create a safe margin. Essentially, turn that Bilski 2 or 3 into a postoperative Bilski 1C or less.
Oh, so surgery creates the safe window for SBRT later.
Precisely. It clears the way, reduces the immediate neurological risk, and then SBRT can be safely considered to treat the residual tumor with a high dose. It's often a planned, multi-step approach.
Okay, that makes complete sense. So back to our case patient, the 68-year-old woman. Her Bilski grade 1C fits perfectly. No compression, just abutment. Ideal.
Exactly why she's such a good example. Stable spine, radioresistant tumor, and crucially, no significant cord compression. Check, check, check.
All right. Now let's tackle something you mentioned earlier, the evidence. There's actually some controversy here regarding SBRT versus conventional RT for pain, isn't there? It's not totally straightforward.
Not at all. And it's really important for residents to understand the nuances of the two key trials that often get discussed because they seem to point in different directions initially.
Let's start with the one that caused a stir, the negative trial, RTOG 0631.
Right. RTOG 0631. Published relatively recently, 2023. It compared single fraction SBRT using 16 or 18 gray against a single fraction of 8 gray conventional RT standard palliative dose.
And the results were surprising.
Very surprising, even counterintuitive. The primary endpoint was pain response at 3 months. And SBRT actually did worse. Pain response was about 41% with SBRT versus 61% with the conventional 8 gray.
Worse? How could that be? We think of SBRT as more potent.
Exactly. It made everyone scratch their heads. When you dig into why that might have happened, a couple things stand out. First, the SBRT dose, 16 to 18 gray single fraction, might actually be on the lower end of the SBRT spectrum. Maybe not ablative enough for consistent, robust pain control across all histologies.
Okay, maybe the dose wasn't high enough compared to other SBRT regimens.
Potentially, but perhaps more critically, the trial didn't systematically screen for spinal stability using SINS scores.
Ah, so they might have included patients with unstable spines.
It's possible. And treating an unstable spine, especially with a high single dose, could theoretically worsen pain or lead to complications that mask the benefit. Lack of stability screening is a major potential confounder. It really highlighted how crucial patient selection is.
Okay, so that's the negative trial, RTOG 0631.
Yeah.
But then there's CCTGSE 0.24. That one came out a bit earlier, 2021, and had a different result.
A very different result. This Canadian trial, SC.24, compared multi-fraction SBRT, specifically 24 gray in 2 fractions against a conventional palliative regimen of 20 gray in 5 fractions.
24 and 2 SBRT versus 20 and 5 conventional. And the key difference in design.
The absolute key difference, and likely why the results were so different, was the inclusion criteria. Patients had to be SINS stable. They used the SINS score explicitly to select patients suitable for this comparison.
So a much more carefully selected, stable population.
Exactly, ensuring the spine could handle the treatment. And in this trial, the results were strongly positive for SBRT.
What did they find?
They looked at complete pain response rate at 3 months. It was significantly higher with SBRT, 35% complete response versus only 14% with conventional RT.
Wow, more than double the complete response rate. That's clinically meaningful.
Yeah, hugely meaningful for patients. So SC.24 provided level 1 evidence supporting SBRT, specifically 24 GD&2, for superior pain control in appropriately selected SINS stable patients.
So how do we synthesize these two seemingly conflicting trials? What's the big takeaway?
The takeaway isn't that one trial is right and the other is wrong. It's that patient selection is absolutely paramount. RTOG 0631, without strict stability criteria and maybe a suboptimal SBRT dose, showed no benefit or even harm. SC.24, with rigorous stability screening and a potentially more effective multi-fraction SBRT regimen, showed a clear benefit for pain control.
So it underscores, know your patient, assess their stability meticulously with SNNS, check their Bilski grade, then decide on the treatment.
Precisely, and it suggests that maybe multi-fraction SBRT, like 24 gray and 2, might be particularly effective for pain response in these well-selected patients. It's not just about high dose, it's about the right dose in the right patient, delivered safely.
Okay, that really clarifies the evidence landscape. Now, assuming we've identified that ideal candidate stable spine, Bilski 1C or less, maybe radioresistant tumor, let's get into the how, the planning and delivery workshop part. This is where the precision really comes in, right? It's a high-wire act.
It absolutely is. There's very little room for error. Everything starts with patient positioning and immobilization.
How do we set them up?
Typically supine, lying on their back. We often have their arms by their sides, maybe legs bent slightly with a cushion underneath to help flatten the lumbar lordosis, making the spine straighter and easier to target.
And immobilization. How do we keep them perfectly still?
That depends on the location. For cervical or high thoracic lesions, say above T4, we use a long head and neck mask. It extends down over the shoulders, providing really rigid immobilization for that critical area near the brainstem and brachial plexus.
Like the masks used for head and neck cancer treatment.
Similar principle, yeah.
Yeah.
Very rigid. For everything else, T4 and below, the standard is a full-body vacuum bag, often called a VacLock bag.
How does that work?
It's essentially a big bag filled with tiny styrofoam beads. The patient lies on it, we mold it perfectly to their body contours, and then we suck all the air out with a vacuum pump.
Creating a custom cradle.
Exactly. It becomes rigid and holds the patient's exact shape, minimizing movement during the scan and treatment. We're aiming for sub-millimeter accuracy, so immobilization is foundational.
Got it. Immobilization first, then the imaging for planning. You mentioned this isn't standard diagnostic imaging. What do we need?
Right. The imaging requirements are strict. First, the planning CT scan. It must be done with intravenous contrast.
Why the contrast?
It helps differentiate the tumor from normal tissues, especially enhancing tumor from adjacent bone or soft tissue, and helps visualize blood vessels we need to avoid. And critically, the CT slices have to be thin, usually 1 to 1.25 millimeters thick.
Thin slices for high resolution.
Yes, essential for accurate contouring. But the CT alone isn't enough. The real key is fusing it with a high-quality MRI.
MRI for the soft tissue detail.
Exactly. But it can't be just any diagnostic MRI. It needs to be a dedicated stereotactic MRI protocol, also with thin slices, acquired in the treatment position if possible, or easily fusible.
What makes it stereotactic?
Usually specific sequences optimized for distinguishing tumor, cord, nerves, and CSF, with high spatial resolution and geometric fidelity. Standard diagnostic MRIs often have thicker slices or distortions that just aren't acceptable for the precision SBRT demands.
So thin slice contrast, TT, fused with a thin slice stereotactic MRI. What if the patient has metal hardware, like screws or rods from a prior surgery? That causes havoc on MRI, right?
Big time. Metal artifact on MRI can completely obscure the spinal cord, making it impossible to contour safely.
So what's the workaround?
In those cases, you absolutely need a CT myogram.
Injecting contrast into the spinal fluid.
Correct. Contrast is injected into the Michael sac, outlining the spinal cord and nerve roots beautifully on the CT scan, even with metal present. It becomes your primary image for cord delineation.
And any MRI considerations with metal.
Yes, another key point. If you do need an MRI on a patient with hardware, you generally want to use a 1.5 Tesla magnet, not a 3T magnet.
Why 1.5T?
The stronger 3T magnet significantly worsens the metal artifact, making the images even less useful. The 1.5T provides a better balance, minimizing the artifact somewhat while still giving decent soft tissue contrast if the myelogram isn't feasible or needs supplementing.
Good pearl. Okay, imaging is sorted. Now, the contouring. You called this the most critical part. Let's walk through it step by step. Step
Yeah.
1, GTV.
Step 1, gross tumor volume, or GTV delineation. This is where you outline all the visible macroscopic disease you can see on both the CT and the fused MRI.
So tumor in the bone, any epidural component, any paraspinal extension.
Everything that looks like definite tumor, you're drawing around the visible bulk of the cancer. Sounds simple, but distinguishing tumor from post-op changes or edema on MRI can sometimes be tricky. Requires careful review.
Okay, GTV is the visible stuff. Step 2, CTV, clinical target volume. Now, you emphasize this is not just a simple expansion in spine SBRT.
Absolutely not. This is a major departure from conventional thinking and a common point of error. Spine SBRT CTV delineation is based on the International Spine Radiosurgery Consortium, or ISRC consensus guidelines, often called the Cox guidelines, after the lead author.
And what's the core principle of these guidelines?
The principle is anatomical and compartment-based. It's designed to cover microscopic spread within the vertebra. You treat the involved vertebral compartments plus the next adjacent uninvolved compartment.
Involved plus adjacent uninvolved compartments. Can you give an example?
Sure. Let's take our L2 patient. Say the tumor, GTV, clearly involves the right side of the vertebral body and the right pedicle.
Okay.
Your CTV would start by including the entire vertebral body, not just the right side. Why? Because tumor can track easily through the bone marrow of the whole vertebral body.
Makes sense. Treat the whole bone compartment if any part is involved.
Right. Then you'd obviously include the involved right pedicle, and then you apply the adjacent uninvolved principle. What structures are immediately adjacent to the right body and pedicle?
The right transverse process, the right lamina.
Exactly. So your CTV would extend to include the right transverse process and the right lamina, even if they look clean on imaging. You're prophylactically treating those connected anatomical compartments to catch potential microscopic extension.
So it's a very structured, anatomy-driven expansion, not just a uniform margin.
Precisely. It respects how tumors spread within the vertebral structures. It's much more complex, but aims for better local control.
Got it. That's a critical concept. After the CTV, step 3, PTV planning target volume. How does that work?
The PTV accounts for setup uncertainties in patient motion. But in spine SBRT, because our immobilization and image guidance are so good, the PTV margin is very tight, typically only 0 to 3 millimeters beyond the CTV.
0 to 3 millimeters. That's tiny compared to conventional RT.
It is. But here's the absolute golden rule, the non-negotiable constraint from the Cox guidelines.
Let me guess. Avoid the spinal cord.
Avoid the true spinal cord or the cauda equina. The PTV should never overlap these structures. You deliberately cut back the PTV margin right where it approaches the cord or cauda.
So you prioritize cord safety over PTV coverage right at that interface.
Absolutely, 100%. We accept a potential slight underdosing at the edge of the target right next to the cord to ensure the cord itself receives absolutely no dose spillover beyond its tolerance. Cord safety trumps target coverage at that critical boundary.
That's a crucial planning principle. You also mentioned sacral contouring has specific guidelines.
Yes, the sacrum is anatomically complex. The ISRC has specific recommendations there too. For example, if you have a tumor lateralized in the S1 and S2 vertebral bodies, the CTV recommendation is typically to include the entire S1 and S2 vertebral bodies, plus the ipsilateral sacral ala, that wing-like structure on the side. Again, it's about understanding those contiguous bone compartments and potential paths of spread in the sacrum.
Fascinating how tailored it is. Okay, we've contoured GTV, CTV, PTV, respecting all the rules. Now, dose. What doses are we typically using?
It varies, as we said, based on histology and institutional protocols, but common single-fraction SBRT doses range from 16 gray up to maybe 24 gray.
16 to 24 gray in one shot. That's a hefty dose.
It is, and often it's prescribed to the 80% isodose line.
Meaning the edge of the target gets 80% of the max dose.
Exactly. It allows for a hot spot of 100% or even slightly more inside the tumor, ensuring a really potent dose hits the core while the dose falls off sharply outside the target to protect normal tissues.
And for radioresistant types like our renal cell patients,
You definitely lean towards the higher end, often 20 gray or more in a single fraction. or use a multi-fraction approach to get a high biological dose. 24 to 27 gray and 3 fractions is very common and effective for these tougher tumors, or 24 and 2, like the SC.24 trial.
Lots of options, but generally aiming for a high BED, a high biological effect.
That's the goal, ablation.
Now, the flip side of high dose, OAR constraints, organs at risk. You said we need to memorize these, especially for the cord. What are the numbers?
You absolutely do. These are your safety net. Let's use the All-Star trial constraints as a common example for single fraction SBRT for the spinal cord itself.
Okay, spinal cord.
The Dmax, the maximum point dose allowed to a tiny volume, 0.035 cc, must be less than 14 gray.
Less than 14 gray max point dose to 0.035 cc. That's incredibly specific.
It reflects the cord's sensitivity to even tiny hotspots. And the other key constraint is a volume constraint. The V10, the volume of cord receiving 10 gray or more, must be less than 0.35 cc.
V10 less than 0.35 cc. So very little cord volume can get even a moderate dose.
Exactly. These two together, low max point dose, very small volume getting moderate dose, are designed to keep the risk of radiation myelopathy exceptionally low, less than that 0.4% figure we mentioned.
Okay, Dmax 14, G to 0.035 cc, V1 over 0.35 cc.
Huh.
Got it. What about the cauda equina, lower down?
The cauda equina, being peripheral nerve roots rather than the solid cord, has slightly higher tolerance. The constraints are still tight, but a bit more forgiving. Vmax to 0.035 cc should be less than 16 gray.
So 16 gray max point dose for cauda versus 14 for cord.
Right. And the volume constraint is V12 less than 0.35 cc.
V12 less than 0.35 cc.
Mm-hmm.
Okay, slightly higher dose thresholds, but still very restrictive volume.
Memorize these. They will come up on boards. And more importantly, they are critical for safe clinical practice every single day.
Absolutely. So assuming we meet those constraints, what are the actual toxicities we might see and need to counsel patients about?
Well, the most common significant toxicity is actually vertebral compression fracture, VCF.
The bone collapsing, how often does that happen?
The incidence is reported anywhere from 6 to maybe 15%. It's not rare.
What makes it more likely?
Several factors increase the risk. Lytic lesions, where the tumor has already eaten away bone, or a big one, like our case patient. Also, a high pretreatment SINS score indicating existing instability. And there's data suggesting single fraction doses of 20 gray or more might increase the risk, especially in already weakened bone.
So stability assessment isn't just for initial SBRT candidacy, it's also for predicting VCF risk.
Exactly. And sometimes, if the risk is high, prophylactic vertebroplasty or kyphoplasty injecting bone cement might be considered before SBRT to shore up the bone.
Okay, VCF is the most common major one. What else?
You can occasionally see plexopathy or radiculopathy, nerve pain or dysfunction from dose to nearby nerve roots, or the brachial or lumbosacral plexus. Less common than VCF, but can be bothersome.
And what about pain flare? You mentioned that earlier.
Yes, pain flare is actually quite common, maybe 15 to 45% of patients. It's a temporary worsening of pain, usually within days of SBRT.
How do we manage that?
It's typically managed effectively with a short prophylactic course of dexamethasone, like 4 milligrams daily for 5 days, starting maybe the day before or day of treatment. It helps blunt that inflammatory response. Important to warn patients it might happen, but it's temporary.
Good tip. And the scariest one, myelopathy.
Thankfully, as we said, in the de novo setting, first-time radiation, true radiation myelopathy is very rare if you stick to the constraints, consistently less than 0.4%.
That's reassuring. The constraints work.
They do, but that risk calculation changes dramatically when we talk about re-irradiation.
Right. Let's pivot to that now. Re-irradiating a previously treated spinal segment. SBRT is a good option here.
It's often an excellent option, maybe the only option to deliver a meaningful dose. But the spinal cord's tolerance is now significantly reduced. Assessing the risk of myelopathy becomes the absolute top priority.
How do we do that systematically? Is there a tool?
Yes, the most practical and widely used tool is the Nieder model. It gives us a risk score based on combining the radiation history.
The Nieder model. What factors does it consider?
It looks at 3 main things. First, the cumulative biological effective dose, or BED, to the cord from all radiation courses combined. Critically, you have to calculate this using an alpha-beta ratio of 2.
Alpha beta of 2 because the spinal cord is a late responding tissue.
Exactly. Using an alpha-beta of 2 appropriately weights the effect of fraction size for late effects in the cord. You sum the BED alpha-beta 2 from the first course and the proposed new course.
Okay. Cumulative BED alpha beta 2. What's the second factor?
The time interval between the treatments. If the interval is short, specifically less than 6 months, the model adds a big penalty, 4.5 points to the score.
Less than 6 months is bad because the cord hasn't fully recovered.
Precisely. Not enough time for sublethal damage repair. Waiting at least 6 months is highly recommended, if possible.
Makes sense. And the third factor?
The third factor is whether any single previous course delivered a very high dose. Specifically, if any prior course had a BED alpha-beta 2 of 102 grays squared or more, you add another 4.5 points.
So a prior high-dose treatment also reduces tolerance.
Yes, the idea is that a very high dose might have exhausted more of the cord's repair capacity, even if the cumulative dose isn't excessive.
Okay, cumulative BED, time interval, and prior high-dose PED. We add up the points. How do we use the final score?
The goal is to keep the final NEATR score in the low-risk category, which is defined as 3 points or less.
3 or less is low risk. What's the risk then?
The estimated risk of myelopathy with a score of 3 or less is generally quoted around 3% or lower, assuming careful planning. Once the score goes above 3, the risk starts climbing much more rapidly.
So practically, what does keeping the score at 3 or less usually mean for planning?
It usually means 2 key things are needed. First, keep the total cumulative BED alpha-beta 2 to the cord below approximately 135.5 gray squared. That number, 135.5 gray DED2, is a widely cited empirical limit based on the NEATR data associated with that low risk level.
Cumulative BED2 below 135.5 gray squared.
And second, ensure the treatment interval is at least 6 months. If you meet both those conditions, you can generally keep the NEATR score low and proceed with relative confidence, though the risk is never 0.
That's a very clear framework for a complex problem. Keep cumulative BED low, wait at least 6 months.
That's the rule of thumb for safe re-irradiation planning.
Excellent. Okay, let's bring this all together now by revisiting our case patient one last time and running through some clinical decision points.
Sounds good. The 68-year-old woman, metastatic renal cell at L2, painful but stable, SINS 5, Bilski 1C, KPS 90.
Right. Scenario 1, we touched on this, but let's definitively confirm. Is she an SBRT candidate based on everything we've discussed?
Yes. Emphatically yes. Let's tick the boxes. SINS score 5. Stable enough. Bilski grade 1C. Yes. Crucial safe window, no compression. Radio-resistant histology, renal cell. Absolutely. Argue strongly for an ablative dose only SBRT can provide. Good performance status, KPS 90. Yes, she can tolerate the procedure. She fits perfectly.
And if any of those were different, if SIS was 14.
Then no upfront SBRT needs surgical stabilization consult first.
If Bilski was grade 2.
No upfront SBRT needs surgical decompression consult first. She really is the ideal intersection of favorable factors.
Okay. Scenario 2, dose recommendation. Given her renal cell histology and the trial evidence, what dose and fractionation would you favor?
Good question. For a renal cell, you want a high biological dose. A single fraction of, say, 20 or 22 gray would be a very reasonable approach, aiming for maximum ablation. It's efficient, too.
Or a multifraction approach.
Definitely. 24 gray in 2 fractions, based on the positive SC.24 trial, is an excellent choice. It has level 1 evidence for superior pain control in stable patients and delivers a potent BED. 27 gray in 3 is another very common, effective regimen.
So, higher dose single fraction or a potent hypofractionated schedule like 24 and 2 or 27 and 3.
Exactly. The key is delivering that high BED needed for renal cell control. The specific choice might depend on target volume, proximity to cord, institutional standards, but all aim for ablation.
Got it. Final scenario. Critical planning goals. When you sit down to plan her SBRT, what are the absolute top priorities, the non-negotiables?
Priority 1. Accurate CTV delineation using the ISRC Cox guidelines. For her L2 lesion, that likely means contouring the entire L2 vertebral body, plus adjacent uninvolved compartments like pedicles or processes based on the exact GTV location. No shortcuts here.
Okay, proper CTV first.
Priority 0, perhaps. Spinal cord safety. We absolutely must respect the cord constraints. Dmax less than 14 gray to 0.035 cc, V10 less than 0.35 cc, for single fraction or equivalent BED for multifraction. This is paramount. We would accept trimming the PTV away from the cord to meet these constraints.
Cord constraints above all else. And finally,
Ensure robust PTV coverage with the prescription dose, typically 80% isodose line covering the PTV, to maximize the chance of durable local control for her radioresistant tumor while respecting the cord constraints. It's that constant balance.
excellent. That really ties it all together. Okay, let's transition to some rapid-fire board pearls. The key takeaways condensed. Pearl number 1.
Appropriate candidates for spine SBRT generally need SINS stable disease, score 0.6, maybe 7.12 cautiously, and a Bilski grade 1C or less epidural compression. Stability and no cord compression are your entry tickets.
Pearl number 2.
The landmark SBRT pain trials, RTOG 0631 and CCTGSC .24, had conflicting results mainly due to patient selection. SC .24 was positive, 24G and 2, superior to 20G and 5 in SINS stable patients, highlighting the importance of stability assessment.
Pearl number 3.
Spine SBRT CTVs are not uniform expansions. They follow anatomical compartments per ISRC Cox guidelines, involved compartments, plus adjacent uninvolved compartments. You need to know your vertebral anatomy.
Pearl number 4. Critical constraints.
Key single fraction spinal cord constraints to memorize. Dmax 14G to 0.035 cc and V1.35 cc per vertebral level. These are your hard limits for safety.
And pearl number 5 for re-irradiation.
Spinal re-irradiation with SBRT can be safe.
Yeah.
IF the interval is 6 months AND. The cumulative BZD alpha beta 2 to the cord is kept below approximately 135.5 chi squared, aiming for a neuter score E3. Calculate carefully.
Fantastic pearls. Ready for a board blitz. Let's solidify these concepts.
Let's do it. Quick fire questions. I'll take the first one. Question 1. A patient has a painful met with epidural extension compressing the cord, but CSF is still clearly visible around the cord. What's the Bilski grade, and is upfront SBRT appropriate? A, Bilski 1C, yes. B, Bilski 2, no, surgical evil first. C, Bilski 2, yes, SBRT standard. D, Bilski 3, no, conventional RT only.
Okay, thinking. Compression, but CSF is visible. That's the definition of Bilski grade 2. It was a Bilski 2 means upfront. SDRT is contraindicated due to swelling risk. So the answer has to be B, Bilski 2. No, this patient requires surgical evaluation first.
Exactly right. Clinical reasoning. Bilski grade 2 definition met. SBRT contraindicated due to risk of neurological injury from post-treatment swelling. Needs surgical consult for decompression first. Perfect. Your turn to ask.
All right, question 2. You're planning single fraction SBRT to T4, which is a critical hard constraint for the spinal cord. AD max 18G, B mean dose 8G, C V12 1.0 cc, or V1 A or 0.35 cc.
Okay, single fraction spinal cord hard constraint. Dmax should be less than 14 gray, so A is wrong. Mean dose isn't the primary constraint. V12 is more for cauda equina. That leaves DV10 less than 0.35 cc. That's the one. That's the critical volume constraint we hammered home.
Correct. Answer is D. Clinical reasoning. V1.35 cc per vertebral level is the widely adopted critical volume constraint for the cord in single fraction SBRT to minimize myelopathy risk, alongside Dmax 14J to 0.035 cc. Well done. Your turn for the last one.
Question 3. Patient had 30 DJ and 10 fractions of lumbar spine 2 years ago, now has focal recurrence. Considering re-irradiation SBRT, what's the approximate cumulative BED? Alpha beta 2 to the spinal cord generally considered a safe upper limit for low myelopathy risk. A 100 G-Di squared, B 120 J squared, C 135.5 G-Day squared, or D 150 G-Day squared.
Re-irradiation safety limit. Cumulative BED alpha beta 2. Interval is good. 2 years, 6 months. We talked about the Nieder model and that key threshold associated with low risk. It was 135.5 gray squared, so answer C.
Bang on. The answer is C, clinical reasoning. Based on the Nieder model, keeping the cumulative BED alpha beta 2 below 135.5 Gg squared, especially with an adequate time interval, 6 months, corresponds to a low risk, around 3% of radiation myelopathy. That's the target ceiling for safe re-radiation planning. Excellent.
Yeah, great blitz. So let's quickly summarize today's workshop. We really covered the waterfront on spine, SBRT, and re-irradiation. We defined the right patients using Bilski and SINS scores.
Right. We dissected the trial evidence RTOG 0631 versus CCTGSC. Point 2, 4, understanding the crucial role of patient selection, especially stability.
We walked through the modern contouring approach using ISRC guidelines, GTV, CTV by compartment, tight PTV, avoiding the cord.
Absolutely. And we drilled those critical single fraction cord constraints, Dmax 14G, V100, 0.35 cc, plus the principles of safe re-irradiation, calculating cumulative BED with Nieder.
So hopefully you listening feel much more equipped now to handle these complex spine SBRT cases, from selection through planning to understanding the risks and benefits.
That's the goal, to give you the framework and the critical details needed for safe, effective practice.
Now, looking ahead, in our next session, we're going to shift locations again. Leaving the spine, heading back up to the cranium, we'll start a new series on non-glioma primary brain tumors.
And we'll kick that off with the most common one you'll encounter, meningioma. Lots to cover there, too.
Definitely. So for ongoing practice, especially for oral boards prep, head over to radonsmartlearn.com. That's radonsmartlearn.com.
And make sure you subscribe to Radonc Smart Review so you don't miss our next deep dive into meningioma. Thanks, everyone, for tuning in.
Thanks for joining us.